We will continue our session about part 819, prostate cancer. Managing complication of locally advanced disease. Bladder outlet obstruction usually treated by TURP, suprapubic tube, or urethral catheter. Urethral obstruction treated with urethral stent or nephrostomy tubes. Persistent bleeding from prostate might be treated with, if we have bleeding, so we can use androgen deprivation in men who are not already on this therapy, if persistent bleeding. If persistent bleeding can do TURB or transurethral catheterizations. Also, we can use for bleeding external beam radiation to the prostate in the men who have not have pelvic radiation. Or embolization. Treatment of non-curable prostate cancer. Non-curable prostate cancer include any of the following. Curative treatment has failed and no other curative option are feasible. So we go to the non-curable prostate cancer. Castration-resistant prostate cancer or metastatic prostate cancer stage M1. This is known as non-curable prostate cancer. Again, can you mention for me the non-curable prostate cancer? Non-curable prostate cancer have any of the following criteria. If the curative treatment has failed and no other curative option are feasible, or castration-resistant prostate cancer, or metastatic prostate cancer stage 1, M1. Treatment for non-curable prostate cancer include castration, that's medical or surgical, androgens, anti-androgens, an inhibitor of androgen synthetics or synthesis, chemotherapy, and immunotherapy. The treatment are discussed in more details here. Castration and castration resistance. Definition. Androgen deprivation therapy can be defined as any of therapies that reduce the binding of androgen to androgen receptor. However, androgen deprivation therapy refer specifically to the castration with or without concomitant use of the first generation anti-androgen. The castration is defined as treatment with surgical castration, that's a bilateral orchidectomy, or medical castration will use luteinizing hormone agonist and gonadotrophin antagonist. Okay, so luteinizing hormone agonist and or gonadotrophin releasing hormone antagonist. Okay, so this is known as medical castration. Medical castration is reversible, where the orchidectomy is irreversible. Luteinizing hormone agonist and gonadotrophin releasing hormone antagonist and orchidectomy are equally effective in controlling prostate cancer. There is limited evidence that the orchidectomy and gonadotrophin releasing hormone antagonists are safer than the luteinizing hormone releasing hormone agonist because they are associated with fewer cardiac events, especially in men with known cardiovascular disease. Castration naive defined as no previous treatment with castration. Castration-sensitive prostate cancer, CSPC, defined as prostate cancer that has not been previously treated with castration naive, or that is responding to the castration. I mean, the PSA and cancer volume are not increasing. The CSPC is also called hormone-sensitive prostate cancer. Castration-resistant prostate cancer, CRBC, defined as prostate cancer that is no longer responding to the castration. I mean, the PSA and or cancer volume is increasing, even though serum testosterone is less than 50 nanogram per deciliter. Monotherapy is defined as use of only one therapy of ADT. Combined androgen blockade, defined as treatment with castration and the first generation non-steroidal anti-androgen. Medical castration is typically administered continuously. However, intermittent medical castration is an option for some men. When starting a luteinizing hormone agonist, be aware of the flare phenomena. If indicated, administer first-generation anti-androgen to prevent the flare. The gonadotropin hormone antagonist and orchidectomy do not cause a flare. Combine androgen deprivation therapy castration with the first-generation anti-androgen. Study the examined combined ADT use luteinizing hormone agonist and orchidectomy for castration. Combined ADT significantly improve overall survival, up to 5% after 5 years of therapy, compared to castration alone. But its use must be balanced against the greater side effect and cost. In essence, combined ADT confers a statistically significant improvement in overall survival, but the clinical benefit is questionable. Nonetheless, combined androgen blockade should be considered in men starting androgen deprivation therapy. There is minimal data to support the use of the first generation anti-androgen with a gonadotropin releasing hormone antagonist. Thus, combined ADT is typically used only with luteinizing hormone agonist or orchidectomy. Castration is recommended part of the initial management of metastatic stage M1 prostatic cancer. Relugolix or oral gonadotropin hormone releasing hormone antagonist. This should not be used with abiraterone, enzalutamide, darolutamide, or ablutamide because of potential drug interaction. Relugolix has not been adequately studied when used in combination with chemotherapy, abiraterone, enzalutamide, darolutamide, or ablutamide. Monotherapy with either steroidal and non-steroidal anti-androgen instead of castration is not recommended because it's less effective than castration. However, it might be discussed as alternative in men who cannot or will not undergo castration. Compared to castration monotherapy with the first generation NSAID anti-androgen result in lower overall survival, higher rate of gynecomastia and breast pain, less hot flush and fatigue, significantly better quality of life in the domains of sexual interest and physical capacity, no impairment of libido or erections, no osteoporosis. This is very important in compared to castration monotherapy with first generation non-SAID anti-androgen result in lower overall survival, higher rate of gynecomastia and breast pain, less hot flash and fatigue, significantly better quality of life in the domain of sexual interest and physical capacity, no impairment of libido or erection, no osteoporosis. Non-SAID anti-androgen are FDA approved for prostate cancer when used with castration, but they are not FDA approved for monotherapy. Intermittent ADT. Intermittent ADT is an option for men with castration-sensitive prostate cancer. Intermittent ADT results in better sexual function, better quality of life, less side effect when off therapy than continuous ADT. Intermittent and continuous ADT appear to have a similar risk of progression and similar risk of becoming castration resistant. Intermittent and continuous ADT achieve a similar overall survival In some studies, death from prostate cancer is more common on intermittent ADT, where the death from other causes is more common on continuous ADT. This difference offsets each other, so overall survival is equivalent. In summary, intermittent ADT appear to reduce ADT-related side effects compared to continuous ADT without compromising cancer control or survival. Intermittent ADT can be utilized in men with metastatic stage M1 or non-metastatic stage M0 castration-sensitive prostate cancer. A typical protocol used in the study that if PSA declined to less than 4 and there is no clinical progression after 6 to 9 months of ADT, then stop ADT. If the PSA is above 10 to 20 or there is a clinical progression, then resume ADT. In men who develop clinical progression, significant worsening of existing metastasis, new metastasis, or significant cancer-related symptoms, stop intermittent ADT and administers continuous ADT thereafter. Men who have significant ADT-related side effects may benefit from intermittent ADT. Continuous ADT may be better than intermittent ADT in the following scenario. Also, the evidence is poor quality. So if men who have a minimal or non-bothersome ADT-related side effect, these men are unlikely to benefit from reduction in side effect while on intermittent ADT. Non-metastatic prostate cancer stage M0 with grade group 4 or 5, Gleason score 10 to 8 to 10. Or for this man, median overall survival was 14 months, longer with continuous ADTs compared to intermittent ADT. Metastatic prostatic cancer stage M1 or PSA more than 4 at 7 to 8 months after starting ADT. For this man, continuous ADT may be best because their median overall survival is only 1.1 years. We come to the last part of the lecture is prognostic indicator after castration. A PSA more than 0.2 nanogram per ml at 7 to 8 months after castration associated with high risk of death from prostate cancer in men with biochemical recurrence after curative therapy, M0 with raising PSA, and is in men with metastatic M1, metastatic disease M1. So this is prognostic indicator after castration. We look for PSA more than 0.2 nanogram per ml at 7 to 8 months after castration associated with high risk of death from prostate cancer. The higher the PSA at this time point, the higher risk of mortality. This is the PSA by nanogram per ml at 8 months after castration for M0 prostate cancer with raising PSA after radical prostatectomy or external beam radiation. And this is a 7 years prostate cancer specific mortality. So if the PSA at 8 months after castration for M0 less than 0.2 or equal 0.2, so the mortality is 2%. 7 years prostate cancer specific mortality 2%. If the PSA at 8 months after castration for M0 more than or equal 0.2, so the 7 years prostate cancer specific mortality 49%. This is the PSA at 7 to 8 months after castration for M1. Here, for M1 prostate cancer, less than 0.2, the approximate median overall survival 6.2 years. And if more than 0.2 and less than 0.4 or equal 0.4, it is 3.7 years, approximate median overall survival. And if more than 4, it's 1 to 2 years approximate median survival. How low should testosterone be after castration? A serum testosterone T should be less than 50 nanogram per deciliter after castration. This level was defined more than 40 years ago when testing was less accurate. With modern testing methods, some data suggests that the breaking through T testosterone more than 20 nanogram per deciliter indicate the risk of progression to the castration-resistant prostate cancer. Therefore, some clinicians use a test testosterone less than 20 nanogram per deciliter decline adequate response to medical castration. Okay, so the old definition is less than 50 nanogram per deciliters. This is the testosterone. This is indicate that the testosterone is low. Okay, but the new guideline here, that's 40 years ago, but this is the new definition is less than 20. This is the evaluation of raising PSA after castration, PSA increasing at least 1 month after castration, obtain serum total testosterone, testosterone less than 50 nanogram per deciliters, more than 50. Castration, here we have castration-resistant prostate cancer, perform metastatic evaluation, management of castrate-resistant prostate cancer. Here, that's more than 50, repeat testosterone to rule out laboratory error, rule out exogenous testosterone source, receiving luteinizing hormone agonist or antagonist gonadotropin hormone, biliary bilateral orchidectomy was incomplete, start medical castration, recheck PSA and testosterone, and then go to PSA again. Okay, so if the patient receiving luteinizing hormone agonist or gonadotropin hormone antagonist, patient not compliant with medical castration, consider bilateral orchidectomy. And here, if the patient also have possible improper injection of faulty dose, given another dose, recheck PSA and testosterone. If testosterone less than 50, do PSA again. If testosterone more than 50, inadequate response, go to consider bilateral orchidectomy. PSA doubling time less than 3 months at any time before or after castration shows high risk of death from prostate cancer in men with biochemical recurrence after curative therapy, M0 with raising PSA, and in men with metastatic disease, M1, prognosis improve as PSA anti-androgen derivative therapy increase. All men with CRPC should undergo bone scan, pelvic imaging, chest imaging when castration resistant is initially diagnosed because they have more than or equal 10% risk of positive bone scan even when the PSA is low and PSA doubling time is low. Castration-resistant prostate cancer (CRPC) is present when PSA is after surgical castration, orchidectomy, or medical castration. Luteinizing hormone agonist, gonadotropin hormone antagonist, despite having a serum testosterone less than 50 nanogram per deciliters, the cancer grows despite castration. The CRPC has also called hormone refractory or androgen independent. However, the preferred term is castration resistance. The PSA can be raised when the castration is not adequate. Therefore, the serum testosterone level must be checked when the PSA is during the castration. If the testosterone level more than 50 nanogram, then castration is inadequate. If testosterone less than 50, then the patient have CRPC. The prostate cancer responds to the castration for an average of 2 to 3 years before CRPC develop, but The response can range from months to 10 years. In men with a CRBC, some cancer cells still respond to androgen suppressions, thus castration should be continued while other cancer therapy are administered. Retrospective data suggest that the continuous castration CRBC improve overall survival. All men with CRBC should undergo bone scan, pelvic imaging, chest imaging when castration resistance initially diagnosed because more than or equal 10% risk of have a risk of bone scan, a risk of positive bone scan even when the PSA is low and PSA doubling time is low. Okay, thank you very much.